Hey there, this is Delve, the podcast from McGill University where we want to change how you think about management. My name's Eric DeCare, I'm Delve's managing editor, and I'm your host today. So today we're going to spotlight an often undervalued part of healthcare organizations, middle managers. So these people spend their days supporting doctors, organizing patients, and managing critical resources. And yet, when politicians or healthcare executives want to cut costs, middle managers are often among the first on the chopping block. So for Giovanni Radaelli and Andrea Daddario, two experts in healthcare management, this can be a concern. For them, middle managers are often vectors for ideas and innovation, and they're often the glue that holds an institution together. So they join us today to tell us exactly how. So Giovanni is an associate professor of operations management and a reader at the Warwick Business School. So he published a study documenting the experience of middle managers in 12 Italian hospitals. Andrea Daddario is an organization development and leadership consultant in healthcare in northern regions of Canada. And as you'll hear, even though they're from very different healthcare contexts, the experience of middle management in healthcare is often more similar than you might think. So, with that, let's delve into it. Andrea Daddario and Giovanni Radaelli, thank you so much for joining. Welcome to the Delve Podcast.
Thank you.
Thank you so much.
So you're both joining from very different parts of the world. So Andrea, you're based in the Northwest Territories. You're calling in from there, and you've done a lot of interesting work in the rural north of Canada and kind of the more remote regions of our country here. And then Gio, where are you based right now?
I'm in Birmingham in the United Kingdom. I'm originally from Italy, but I've lived in the UK for 12 years now.
Okay, very cool. Yeah, and then you're also one of the co-authors on this interesting study that was co-authored with my editor-in-chief, actually, Professor Saku Mantra, and then Graham Curie, looking at middle management in Italian hospitals. So yeah, I think, there's a lot to learn from there for pretty much any kind of manager in any organization. I think they'll be able to relate to a lot of this, but I think in healthcare, the stakes are a bit higher. So when we're thinking about this, when we're thinking about the internal dynamics in a healthcare setting like this, how do these affect the delivery of care? Gio, I wonder if you can kick us off and maybe speak to that a little bit.
Yes. I think it's a great question. And I think we have a lot of evidence that collaboration, cooperation, coordination is essential for the delivery of care. And a lot of our attention has been on the collaboration between clinical departments, so sort of horizontal collaboration. And there should be even more evidence that collaboration across different management levels is also as important for the quality of care for a number of reasons, which is great ideas for process improvement, service improvement come from different parts of the organization. Some come from the front line, others from executive board, because they are mostly in contact with, for instance, the regulators and the external environment, and also from the middle management, which is also a great interest of mine. There is a whole tradition of literature that says, backed with a lot of evidence, that most ideas, strategic ideas, improvement ideas actually start from the middle and then they spread across the organization. And because there is such an emphasis now on flat organizations, agile organizations, we are seeing how little investment there is in growing middle management, and almost an idea that middle management is a nuisance that needs to be removed from organizations, despite evidence that this has always been a problem, because it means getting rid of knowledge, resources, capacity that only the middle managers are able to provide.
This is, what I think so important, and what the research, what Gio and your team have captured is something so important here is integration is not just the technical expertise and challenge. It is a relational challenge. So when you have clinicians and middle managers and executives that are working hard but are still fragmented or disconnected, maybe operating from different pressures without that alignment, I see that the fragmentation shows up in transitions, communication, implementation, innovation, sustainability, staff well-being, and most importantly, the continuity of care. It's, we set up these great programs, but what happens once that pressure is over and there's no support after? So it's really interesting. We can talk all about organizational dynamics, but it's not something that's separate from patient care in my experience.
So, I mean, like, this paper, Gio, like you're very much focusing on middle managers and kind of like how they interact with two groups in particular, looking at clinicians and looking at executives. And my reading of it, it just seems like they're kind of stuck in this awkward position, So, I mean, Andrea, I'm curious, like in your experience, like, what is the typical dynamic between managers, clinicians, and the executive team? Because like it feels like they might be kind of pulling in a lot of different directions.
Yeah, I think it's a great question. And I think in my experience, is it an awkward position? I think it can be a very awkward position, but I feel like they're translators. So middle managers are the translators. We often say they're the muscle. They're the main pump that get things moving. But they're also existing in competing realities. So for example, we know our executives, they're carrying organizational sustainability, workforce pressures, strategic priorities, accountability pressures, resource limitations in our particular situation. We know that clinicians are carrying the weight of patient care, workload, professional ethics, clinical autonomy. But the middle managers are trying to operationalize all of that simultaneously. And so in remote healthcare systems, the tensions can intensify. So that awkwardness that you're talking about, I think that's a tension, and it can intensify because maybe our systems are smaller, or maybe they're new, maybe they're just beginning. Like we talk a lot about maturity, that we're young and we're still figuring this out. So some of those pressures can show up at different times. Our relationships are closer, believe it or not. We have very close relationships that maybe some larger jurisdictions may not. We wear multiple roles or hats. So we often say, how many hats are you wearing right now? How many jobs are you carrying from a managerial level? And I think in that sense, the awkwardness is that when you have those relational breakdowns, if they happen, they're felt very quickly because of that.
So that's in the north, but so Gio, in your study, like in Italy, I'm curious how things played out in that setting. Like, what was the situation there?
Yeah, I think it's very, very similar. And I've done most of my research initially in Italy, and at least initially mostly in Italy, and now mostly in England, in the United Kingdom. And despite the fact that they are quite different healthcare systems, the dynamics within organizations seems to be more or less comparable and very similar to what Andrea was mentioning. And what I was noticing in my research is how many different roles exist in hospitals that are about improvement, service improvement, and quality safety. And it's not just that some middle managers have multiple roles and multiple responsibilities, but also that the same responsibilities shared across very different managers that sometimes are not even aware that there is another person in another office doing something quite close to what they're doing. I think there is this great element that Andrea mentioned about, this middle management being the muscle of the organization. But sometimes they're not particularly recognized for the role, and that's something that I think it's a bit concerning. And one of the reasons why I wanted to do this research is to show both academia and practice seems to put too many eggs on the basket of clinicians and executives, and there is a whole branch of literature that actually says we should remove middle managers without a clinical background and ask clinicians to take on responsibilities that middle managers have. And this is not great for middle managers because it pretty much means taking their jobs, but also for clinicians because they're very busy people asking to do a lot, and then we ask them to do even more tasks. And this is, I think, quite a general problem, because it's informed by an almost universal lack of recognition for middle managers as people that, as you mentioned earlier, are vectors of ideas.
I mean, Gio, in your paper, you looked specifically at a type of manager called quality managers. And so these were folks who their roles kind of overlapped with clinical professions to a certain degree. And it seemed like that was a motivator for folks to kind of assert themselves and to kind of try to claim their space and prove their value. So I wonder if you could speak more about that. Like, what was the root of that whole dynamic?
Because the work of a quality manager overlaps with clinicians, there is a tendency to decentralize responsibilities from management to clinicians. And then there is a lack of investment in quality offices, at least when I did that research, and a feeling of we are being underutilized and we are going to disappear soon, because there is a future where the organization will decide to give these responsibilities to clinicians. What really struck me was how much those quality managers felt an urgency to prove their value in the organization. Members of one quality office, actual operations management office, quite consistently define themselves as frogs in the pond, with this idea of we need to be jumping across different parts of the pond because we need to be seen as active. We need to be in different environments, because that kind of visibility is important for us to be taken seriously. And it's really about building relations and making sure that we show how we have a unique contribution, unique value that others cannot really replace.
And they're not fighting for power just for the sake of power. They're trying to, establish legitimacy in a system where it's articulating that there's a need. We have a need for this, and there's an expectation of change without always granting, in my experience, I always granted the equivalent authority to actually influence that change. So it's interesting that you say that they felt they had to, hop across the pond or jump the pond. Something that always came up for me was, it was like, the bounce and the glue. They're the rubber and the glue. They have to bounce and stretch, but they also have to hold things in place once they get there. And there's this volatility in that holding in place where how long is it sustainable for us? And then, of course, the dynamic is there's a lot of relational work in there. There's a lot of relational investment in holding that in place once you get there, or even holding it in place for a period of time. And then, you think about resource-constrained environments where that, through a system lens anyway, that becomes so much more important, because an organization that may be geographically diverse or smaller or more remote can't afford that fragmentation from an outcome perspective, certainly. So, I think many quality and organizational professionals have experienced being asked to coordinate major system initiatives while simultaneously lacking the supports and legitimacy that they need to actually see that through.
Yeah, and you mentioned the politics, and I thought quite fascinating in this specific study how there were a couple of cases of quality managers that were quite clearly playing like a political game, because they wanted to become like the future CEOs, and they were quite quickly discovered and sort of put aside because people didn't find their motivation quite genuine. While the most effective ones were the ones that really saw we have a specific competence that could help patient care. We see patient care in a way that clinicians maybe do not. It can complement the way clinicians can work, for instance, by using like a more process-oriented mindset and tools. And it's pretty much getting in a relational game, which is we can help you and we're not trying to dispossess you of anything. It's pretty much, look, we have a toolkit that we can share with you. We have capacity, we can spend time, we can allow you to save time so that you only think on your clinical work rather than having to bother about all the admin management stuff that we can actually be bothered with.
Yeah. Oh, that's super interesting. Yeah. Well, I'm happy you mentioned that, the contrast between motivations there, because yeah, I think there's a version of this where, yeah, you can look at this and be like, well, yeah, of course middle managers are trying to assert themselves because they don't want to lose their jobs. But there's that, but there's also, there's some folks who truly believe that what they're doing is bringing value to the organization. They're there to help, like, a lot, you know, you don't get into healthcare without caring a little bit about trying to make a difference and hopefully, you know, affecting people's lives in a positive way. So
yeah, when we think about vocation, obviously we link that rightfully so to clinicians, but there are plenty of non-clinicians managers that also want to work in the NHS or in healthcare in general because of, you know, their attention to patients, to social care and so on. So managers do come from a place of we want to help.
well, okay. So, Andrea, I mean, I'm curious if we can think about this from a leadership angle, because, like, just thinking about how to bring all these groups together, different kinds of managers, like kind of reduce that fragmentation, increase that collaboration between different teams. How should leaders be thinking about this?
I think one important piece to recognize is that what is intentionality in complex environments? How are we intentional about this? So we brought in this notion of being intentional in our practice, recognizing that most of the time we're operating on full speed. That ability to slow down is not always there. But the conundrum really is, well, how do we build that in intentionally so that we are supporting where we need to? What should we be thinking about? We should be thinking about calibration. What are those trigger points when we need to recalibrate? Alignment. I think that's come out pretty loud and clear in the research as well, is that alignment piece, but reflection. So when we say reflection, you know, sometimes we get it's the loudest eye roll in the room. Okay, but can we slow down just enough to align, recalibrate, check in, and listen radically?
What do you mean by recalibration?
Recalibration may mean, so, you know, Gio, you mentioned process strengths or strategies. Those processes can change so quickly. External environmental factors can play a role, internal changes, leadership changes of direction. So we do need to calibrate. And I think the earlier the more intentional you are about building in those checks, those internal checks, it helps mitigate any of those downstream impacts when things change abruptly. And maybe it's like, okay, we're looking at a quarter, or we're looking at the next 6 months, or maybe you kind of see the horizon while you're also in the weeds.
Yeah. Yeah, that makes me think of the pandemic when everything was changing rapidly, like being able to stay up to date on the latest thing and trying to get everyone on the same page about, what the latest rules were, like how to approach like the latest strain and that kind of thing. Like, yeah, those conversations are super important. Gio, I'm curious, do you have any thoughts there?
Yeah, absolutely. I mean, the idea of intentionality is great. So I completely agree with Andrea. And sometimes I've seen executive leaders that sort of want to take inspiration from non-healthcare environments, where sort of cutting workforce is a message you send to your shareholders as, oh, I'm being efficient, I'm cutting down waste. And that's kind of mindset, when it's applied in organization, in context without that capacity, can be very dangerous and has led to a lot of missteps, in my opinion. So to me it's important for again, looking at my own personal experience in some research I've done, certain CEOs come and think they can change using like logics that are foreign to healthcare. They need to understand this is a very peculiar setting that works on certain principles, because the quality of care is not making money. It's a different outcome, and you need to shape your leadership principles with that goal in mind, not with, oh, we need to save money. That is one of the main considerations I had about leaders. And the other one, and then I'll pass the ball again to Andrea, I've heard a lot of conversations around labor and I think there is a great recognition of frontline labor, so clinicians, and how they need to be more strategically involved and so on. And I thought when I was a bit younger that this was leading to a sort of division of labor mentality, where we recognize that strategic work needs to be divided and then integrated across levels. Where I think there is a tendency for executive leaders to foster a climate of separation of labor or substitution of labor, where you take some of the work that you would have asked to middle management and give it to clinicians, and you make both unhappy for the reasons I said before. So it's pretty much, it's fine that strategic work is broken down and divided into different players, because that allows people to have time to focus on their portion. And then it's about integrating them, not asking one to do everything at the expense of somebody else.
Yeah. There's so much, Gio, that you said. I think we need many hours to talk about this, but if I can just, position perhaps to what success could look like. What were some of the leadership success? And in my experience is when you have executive who understand and trust the expertise at the table, that's a huge leverage. And it's that support saying we sponsor this work. We understand the work that's involved in this. So I guess maybe there's some more work to do in some areas around showcasing the value of that work and the value of the relationships. So it's almost as if go forth and do well. We're going to support you. The other asset that I often see is in busy environments where we know people are stretched clinically, we look for leverage points where they're naturally coming together. Are there opportunities? And this really butts up against, in my experience, infrastructure and process. So for example, do you have quality team meetings? Are we sharing locally across units and teams? That's a place to shine a little bit of a flashlight to say, okay, if we don't have that, maybe that's a starting point. Because or are there times where we're already meeting and sharing this anyway? Could we really leverage that time? Because that shares that workload distribution. It creates a space to have the conversation, creates the space to collaborate. Now, as I say this, it's not always perfect, but there's a messiness in this that you get your stride and you start to build some momentum. Again, recognizing that each level of that system, small, large, geographically diverse, understands that these are all integrated parts of a very strong muscle that need to work together, just like we would in healthcare. We know. We know that if we get that the mechanics working, we could build strength in that work. So I'm going to leave it there, but I think we could talk about this for hours.
Yeah, no, that's a great note to end on. Thank you. Well, listen, thank you both. I think this is, I'm really grateful for this opportunity to kind of shine a light on this part of the healthcare system that maybe we don't get to talk about very much, and to sort of elevate middle managers and just like in their contributions. I think it's important. So Gio, Andrea, thank you so much. Really appreciate your time.
And thank you, Eric.
All right, that's the show. A special thank you to Andrea Daddario and Professor Giovanni Radaelli for their time and insights today. This conversation was based on a research paper by Giovanni, which he co-authored with Graham Curry and Professor Saku Mantra from right here at McGill University, so I'll leave a link in the show notes for you to go check it out. And if you're not subscribed to the Delve Podcast already, please go do it right now. So we publish conversations just like this one almost every 2 weeks, where we try to bring you management insights from across disciplines that are hopefully going to expand your view of management as a practice. So check out the links in the show notes for other pieces of content that might spark your interest. So Delve is the official thought leadership platform of the Desautels Faculty of Management here at McGill University. My name is Eric DeCare. I'm Delve's managing editor, and I was your host today. Professor Saku Mantra is Delve's editor-in-chief, and he produced all of our original music. So that's all I got for now. Thank you so much for listening, and we'll see you next time.